All right. I think we're good. Yeah. All right, guys. Appreciate everybody coming, for everybody who's online right now. Today is, obviously it's conference, but it's Fellows Conference. And for those of you who are familiar, Fellows Conference is something that we all look forward to, because rather than having me dictate the learning, the fellows get an opportunity to talk about something that they find interesting. So Dr. Gorman is here today to talk a little bit about Rotem, which I think we could all benefit from better understanding of Rotem, including myself, because if you don't use it, you lose it. So Rotem, demystified. Take it away.
All right. So again, I know for those that don't know, I think I'm with everybody in the room. For those that are not in the room, there's a lot of tech happening up front, so I have to present on my iPad, and then I'm also on my laptop just for how some of the graphics, so if it's choppy or delayed, just kind of bear with me. So I'm going to talk about Rotems. We used it a lot in residency where I was, and it's something that I think is, one, really interesting, like Dr. Bartok said, and two, I think has a lot of good applications, and it's underutilized. So for the objectives, we're going to go through the clotting cascade, just quick background stuff, and then with your laboratory evaluation of clotting. Then I'm going to go over the Rotem and Tank basics, because on your test you are going to be tested on Tank because it's used a little more in the US, and then Europe, Rotem's a little more popular. So I just want to make sure you're aware of both. Then we'll go over some basic graph interpretations and diagnosis, talk about some transfusion protocols and products, and then is this better?
Is that better for everybody at home?
Yes, thank you.
Okay. And then we'll go over the literature, because I think that's important to know what's evidence-based, what's been proven, what's not been proven. And then I want to end with a bunch of just examples and graphs, so everybody can kind of take a look and become comfortable. So in terms of disclosures, other than the text stuff, there is some stuff that's evidence-based in this talk. There's some stuff that just is physiology-based and sort of interpretation of different graphs. So I'll try to make it clear of what's been played out in clinical trials and what hasn't. And I really want this to be interactive. This is difficult material, so if you have questions, just feel free to raise your hand and ask questions. And then the last part is I learned how to do this on presentations. So just kind of get ready for a lot of this, a lot of drawing, because I think it helps with graphs to kind of understand what you're looking at. So this is your basic clotting cascade that I think everybody understands, and you learn in med school. You learn all the basics. There's extrinsic pathway, intrinsic pathway, and then you have a common pathway. There's a lot of cofactors. There's a lot of feedback mechanisms. There's a lot of amplification and a lot of regulation. And I think in terms of Rotem, it'll get a little overwhelming if you're trying to picture kind of all of this at once. So what I want you to do is picture more of this version, and that was really choppy online. I'm sorry about that. But this is really all the clotting factor that you need to know to understand it. So you really just have to know the basic clotting factors, what process you're at, and then when you get to the bottom with the platelet amplification and aggregation, those are kind of the basic steps. So if you can have this and correlate it to the graph you're looking at, you'll be able to interpret pretty much everything you see. As part of the talk, you really need to have a little bit of background on the tests that we're doing and why Rotem is better, why maybe it's worse in certain situations. So to run a PT, just to refresh everybody's memory, you take a blood sample in a tube, you spin it down a centrifuge to platelet pour plasma, and then you have to incubate it to 7 degrees, and then you add calcium. Basically, all it is a quantitative measure of your clotting factor. So 7, 10, 5, 2, and 1, and it's not going to have any of those feedback mechanisms. It's not going to have any of the platelet components, and remember, platelets are a big part of the feedback and amplification. So it's really just a linear kind of static measurement of clotting. The next thing that we use all the time is PTT, or activated PTT. Again, it's your platelet pour plasma. You have a silica or cellite or kaolin added to the vial that basically activates 11 to 11A, and so you run the intrinsic pathway. Same thing, it's just linear static measurement. It'll test all those factors listed. I think we all kind of know that. But the big thing on these pictures is it takes time. It's not a quick test. and that's one of the biggest advantages. This is also new information to me in terms of how it's actually run. So your fibrinogen in a lab, it uses, most commonly is called a Klaus assay, and it's automated, but you again have to spin down blood to plasma that's platelet poor. You add a huge dose of thrombin. So basically you go to the step here, hold on a second. Sorry about that. To here, and it says we're going to add all this thrombin to the point where we're just going to start at the fibrinogen pathway. And then you look there in the tube, and it just, how long does it take this plasma to clot? And then you hit a stopwatch, and then that's compared to reference values on a big sheet, and that's basically how you get your fibrinogen value. So the big point of that, in addition to how it's done, just to kind of know, is it also takes time, so it's not a quick test either. So now let's get into what we're here to talk about a little bit. So Rotem and Tank. So the basics of it is you take a blood specimen and you add it into a cup that has a wire in it that either rotate or spring oscillates. Tag is just a rotational force, and then Rotem, it's kind of spring and oscillating. And the feedback mechanism is the resistance of the blood in the cup. So if you think about if the cup's full of water, you're not going to have any resistance. It's just going to spin and spin and spin, and that's no clot. You're not going to get any graft. But as the blood thickens and starts to clot, you get more resistance. And so that's kind of what it bases the graph readout on. And the big difference is, one, the machinery is a little different. And then with Rotem, instead of a wire twisting, it's a spring oscillator with a ball bearing. But you still, that's not really that important in terms of the difference of the two. What you have just for TAG, because it does show up on our test, it's not the point of the talk, but it was developed in 1948. It was a company, Haemonetics, I guess is what it's called. I didn't know how to pronounce it. This is from their website. It's basically, you measure all phases of hemostasis in the blood is what they advertise. So it's FDA approved in 2019, was added for trauma uses and into pre-existing uses for cardiac surgery and liver transplant. One difference that I think will make TAG a little more popular moving forward, I don't know about cost, but in 2019, they also got approved cartridges. So it takes the pipetting component out of it. What you have to do for a Rotem or a TAG is you micropipette blood into your vials, and then you have to add it to the machine. So it's a little more labor intensive. So these cartridges are a little nice because they're more user friendly. You just add a drop of blood into a cartridge and then kind of plug it in. So I think the cost is still incredibly high though. But that's just for completion's sake. I just wanted to talk about that. So the values you'll get with TAG, and you don't have to really memorize this, they correlate to things I'm going to talk about in the Rotem graphs, are you have your first R time, which is basically, it's going to have no resistance, and then all of a sudden it starts getting resistance, and that's your R time. And that's basically when fibrin is starting to be deposited up to 2 millimeters in the cup. So that's your resistance. Basically, anytime you get resistance. Then your K time is the time it takes. You go from the angle here to here. So basically, it's a height of 2 millimeters up to a height of 20 millimeters. And that is your K time, and it's more of an angle. And you can have an angle that's also reported, but it's the same value, essentially. So K is a time, and then angle is, of course, an angle. Your MA is how strong the maximum clot is, essentially. So what's the maximum thickness of that clot, aka what's the most resistance the wire gets, and that's how it interprets the clot. And then LY is just how much clot is broken down by fibrinolysis after 30 minutes. So those are your basic values. They're very similar to Rotem, so we don't have to dwell on them too much. So for Rotem, you have the same thing. 1948, they both kind of came into play. Rotem kind of has a market share in Europe. So it's much more common in terms of European studies to see Rotem. It was FDA approved in 2011 for trauma surgery, in addition to existing cardiac surgery and liver transplant. And like I said, the machinery is a little different, but for what we need to know, it's essentially the same thing. So you have the oscillating cup. It gives you the feedback as the blood gets more thick, and that's really the gist of it. So your graph, the values are a little different, but I think they're easier to remember. So your CT, which is that first part right here, is your clotting time. So that's the same thing. It's essentially you get no resistance on the wire, and then all of a sudden you have resistance. So you're getting some fibrin deposition at that point. Your clot formation time is that pink time right there, and that's the same thing. It goes from 2 millimeters thickness up to 20 millimeter thickness of clot. So whatever time it takes to do that is your clotting time. The angle is the same thing, called the alpha angle. It's the same thing as a slope. You don't really use that. So I just wanted to put it there, but the values we use are the clot formation time. It's more based on the time instead of the angle. A10 is not in TAG, but it's the same principle. So it's your thickness of your clot at 10 minutes. That's all it is. Your MCF is the maximum clot firmness, and that's basically the thickest point in the clot, just like the MA of the other one in TAG. And then your lysis index at 30 minutes is how much clot is broken down at 30 minutes, essentially. So to go a little more into the specific ones, so you have your clotting time is that first value. So you have nothing on the wire, and then you're going to stop point right when it starts to hit the resistance. Your next one is the clot formation time, which is that pink area where it's getting to be a thicker, firmer clot, and it measures, it just basically, the graph will stop being pink when it's 20 millimeters thick. And that's not that important, but it'll make more sense when I tell you what it represents in the next couple slides. Your A10, which is just the thickness at 10 minutes. Your firmness is right here. That's how firm it is and thick it is. I'm going to repeat myself a lot because I think it makes it easier to understand. Your lysis at 30 is your 30-minute lysis. And then the last one that is important to note in certain situations is your maximal lysis. So your Rotem runs over 60 minutes. Your maximal lysis is just how much clot is broken down after 60 minutes. And in normal people, it should be less than 15%. So this would actually be an abnormal, but this is the graph that the company generally uses to interpret everything. So what I want you to do for the sake of this talk, at least, and this is me, this isn't something the company represents and tells you what to do and how to interpret it, but it's just what makes sense, and I think it's an easy way to represent. So visualize the graph is actually up and down like this when you're looking at it the first couple times, and then correlate it with the next piece, which is the clotting cascade that comes in right next to it, and kind of associate them with the two in terms of what they're representing. So remember I was saying that when you get up to fibrin, that's your first step. So when you get the clotting time, that really is basically here to here, right? Your clot formation time, which is getting a little tight, and I'll have more drawings about this, is this part. And then your lysis is this part where your plasminogen's breaking down. And then the fibrin and the platelet part is this whole big clot in between. Does that make sense? So another way to look at it is they're on top of each other layered, and then another drawing, and bear with me, I'm not a very good artist, but you can have it like this, and you have your piece come in that's kind of like this. So this is really rudimentary, but I think it's the best way I've come up with to understand what you're actually looking at. So the same thing. So basically your clotting cascade is that Y, and everything up to the fibrinogen deposition point is your clotting time. The clot formation time is basically the fibrinogen on the fibrin making polymers from monomers. So the mesh gets bigger. And then once you get to about here to here, this is when the platelets really come into play. So the platelets are amplifying the process, adding on themselves, the clot's getting thicker. So that'll help you realize what treatments you want to do too, if you kind of realize what spots you're at. And these are the values that are represented in those different spots. And then your last part is where the plasminogen to plasmin, you're starting to break down your clot into split products and D-dimer. And that's represented by your lysis and your Li30 and your maximal lysis. And another way to look at it is just like this. Again, I think it's easy to hammer home. So that's really what you're looking at when you're getting that graph. And try to think of it just like that, because I think it'll help. Okay. For thoroughness, again, clotting time, I think this is a good way to look at it. It's here. Sorry, there's a lag with the iPad. So that's your clotting time. Think of it just like that. Everything above when you have thrombin activating fibrinogen to fibrin. And then your next one is clot formation time, which is here, the fibrinogen to fibrin polymers, making it thicker, bigger. And then the next part is your amplitude 10, which is how thick your clot is at 10 minutes. And that's the part where the platelets are starting to aggregate on themselves. And then finally, you have your lysis at 30 minutes, which is really just representative of the breakdown part of it. And I know the drawings are terrible, but I think this is a great way to think about it. Everybody with me? I know it's a little unusual take on it, but I think it's a good way to understand it when you're starting. Okay, so some specific tests. So this is the next piece. So we always talk about Rotem, but when you get the results, it's really XTEM, INTEM, FibTEM, HepTEM, APTEM, and then I think people get a little lost. And then you get these like wine glass patterns that people talk about that I think confuse it even more because it's harder to remember the wine glasses than it is to just look at the graph and know what you're actually looking at. So I don't like to use those, so let's not do that. And then when you get into the specific tests, here's what they actually mean. So XTEM, basically what they do is you take the cup that's spinning with the wire and you're adding tissue factor into the blood. So you're only activating the extrinsic and comic pathways, essentially. So that's why you run it, because that isolates problems with just the extrinsic pathway. So what it does is identify problems with 7, 10, 5, 2, 1, the platelets, and then lysis. So you'll see all that information, essentially extrinsic all the way down. I think that's pretty straightforward. INTEM is the same thing, just the intrinsic pathway. So they add ellagic acid. I think I pronounced that incorrectly, but it's okay. And it only runs the intrinsic cascade, so it's similar to your PCT. But again, it's whole blood, and it actually shows you what the blood is doing as opposed to just a linear measurement of the clotting factors. And that measures kind of all those factors there. Your FibTEM is the next one. They're all named for how to basically name for themselves, so it's easy to remember the first three. And all that adds is a protein that essentially just blocks platelets. So the information you're going to get on your FibTEM is independent of the platelet component. So when you get to the thick clot, that I'll show, it'll make more sense when we do a bunch of examples. You don't know if the thickness of that clot, do I have a platelet problem or do I have a fibrinogen making fibrin polymer problem? Because you're just gonna know it's not thick enough. And so you run your FibTEM and you say, okay, the FibTEM's normal, so I know it's a platelet problem. Or the FibTEM's abnormal, so it's probably a fibrinogen problem. And that'll kind of change your management on that. Everybody with me there? Feel free to raise your hand and tell me if I'm not making any sense. You don't get, for the FibTEM, it's important to realize kind of what values you're getting. Ignore this, and we really are only looking for right here. And why that is because you're not going to get to a thickness of 20 millimeters in most people without any platelet component. So you're not going to get a clot formation time. That's why this value is 0 right here. Because you have to get to 20 millimeters to stop that stopwatch. That's why it shows up as pink. So the only value that's really important in MCF is the maximum clot thickness, so your MCF. You'll get a clotting time because it's still the same thing, but that should match your INTEM and XTEM clotting time. So I usually just tell people to not look at that part of it because it gets information overload. So the last two are where I think people get more confused. So HepTEM and APTEM are named for the process they block, not the process they represent. So HepTEM adds heparinase, so that degrades all the heparin. So if you think somebody has too much heparin on board, it'll take that away. So if that normalizes from your INTEM, that means that your heparin is too high. Does that make sense? So that's a reagent, essentially, that just degrades all of your heparin that's present. Normally, if that's not a heparin issue, it should be about the same as your INTEM, within a margin of error. So 10 to 15 seconds in clotting time and clot formation time. Then the last one is your APTEM, that it's named for the aproteinin, but it doesn't really help you remember. It's just that one blocks fibrinolysis. So the last one is kind of the one that's not named really appropriately. So that should match your XTEM normally. And if it doesn't, that means that there's a hyperfibrinolysis going on, because if your APTEM normalizes, like in this one, and your XTEM is abnormal, this one's normal, but if it's abnormal, it'll tell you that there's too much fibrinolysis going on, and then you can treat accordingly. So the HepTEM and the APTEM, I really just tell when you're learning, only pay attention to those if those are normal and everything else is abnormal. And then you're done. The interpretation is the easiest one there is, because if it's HepTEM is normal, that means you have too much heparin. And if the APTEM is normal, that means you have too much fibrinolysis and you give TXA. Everybody get that? So you get a lot of information, but I think if you can just put those, make those as easy and basic as possible, I think that helps people understand. So this is your normal results. This is what you'll get normally when you get your Rotem on a patient. And these are all normal values. It's less important to remember what the normal values are because it'll highlight the boxes here they'll literally highlight if you have anything that's abnormal. So it's important to just kind of know what the normal values are, but you'll know because it'll say so on the graph. So these are just for reference for when I send this out, that you can just have it as normal values. But especially Rotem, the graphs will always say what abnormal is. Okay, for completion's sake, I wanted to talk about treatments and just so everybody's on the same page before we start doing examples. So you have your basic FFP, cryo, platelets, and TXA. FFP, the contents, you have all the clotting factors that I think most people know. You also have 400 milligrams of fibrinogen per unit. The dose is usually around 10 to 20 ml per kg. We just say 15 ml per kg. That makes it easy. There is some volume associated with it, but just remember that is some fibrinogen and essentially represents all your clotting factors. Cryoprecipitates, so when we say cryo, that is essentially 140 milligrams of fibrinogen per unit. And it's confusing because you're ordering a pack, not a unit, and a pack is 5 units. So the normal dose, if you want to raise your fibrinogen by 50 for like DIC, say your parameter is 150, is 1 unit per 10 kg. So if you're 100 kilograms, you need 10 units, which means you need 2 packs. And that'll take your fibrinogen up by 50. And it is a little hard to remember sometimes, especially in a pinch. The Cooper order set actually says it right on the top of the product you're ordering, how much to order if you ever forget. But notice 1 unit of cryo is actually less than 1 unit of FFP in terms of how much fibrinogen you have. But the difference is obviously you're ordering 5 units at a time of cryo and not 1 unit. Platelets are the last thing, just talk about. Same thing, 1 unit per 10 kg will raise it by about 50 to 80,000 platelet count. They're essentially a separate mechanism. So if you think the patient needs platelets, then you want to order that. I just want to talk about the dosing quick. It's not as important. And then TXA for the non-EM people, just to refresh, it's 1 gram IV, and that essentially just blocks that conversion of plasminogen to plasmin. So just think of it the opposite of TPA. So you don't have as much breakdown. So if you have too much fibrinolysis, the answer is you just give the TXA and you block the breakdown of that clot. Everybody with me so far? Okay. I think the treatments everybody has a pretty good grasp of. So this is it. I mean, this is a really bad drawing, like I said, but the treatments are here. I mean, it really shows you if you have a problem in the clotting time up top, you're going to give FFP or PCC, of course, if you don't want the volume. If you have a problem in the clot formation time, you're going to give cryo. If you have a problem in the A10 MCF lysis 30 index, it's either a platelet problem, remember, or a cryo problem that I'll show in one of the examples. So you give one or the other, and then if you have too much breakdown, then it's TXA, and it's really that easy. So there's quite a bit of protocols and wine glasses and things like that, but I think if you kind of understand what the graph shows, it makes it much easier. And I'll show you Cooper's protocol in a second, but again, there's all these things that you can find that'll say like, if it's this wine glass, give this, if it's this, give that. But so this is Cooper's transfusion algorithm. I didn't want to talk too much about algorithms because I'd prefer if you just knew what to order based on understanding. So, but it is there if you forget and like can't think of what to order. I think it's on the Pulse page, I wanted to say, but I think if you go to Pulse and search for it, it should come up. But we do have one based on Rotem. Then there's ones at other places. Dr. Malman has a really nice blog about Rotems and what to order and kind of their parameters that they use that they recommend. But there's tons of FOMED on this topic. So if you want to look at protocols, if you're going to graduate and go somewhere else, there's a lot of good examples to pick from. The best one I personally found is the Ascender-Rund algorithm. It's Germany basically created a task force to kind of standardize treatment for this because almost every of the big hospitals use it, and they just wanted to have everybody on the same page with what they're supposed to order. So I think this one's pretty clean and easy. It tells you exactly, you know, with each step, is there a problem here? Is there a problem here? Is there a problem here? And then what to order. So I just wanted to include this just so people have it just as a reference, and I think it's a pretty well done algorithm. So let's talk about the evidence. Most of the evidence are in these 4 topics. There's over 650 trials or papers or publications on Rotems and their use. I think especially in the United States, it's limited given it's going to be a tough sell to say like, outside of those things and bleeding and hemorrhage, say like, I think that XTEM's a better test than INR for cirrhotics, so we're just going to randomize people to XTEM and then they can all get LPs if their INR is like 6. It's a tough thing to get approval for. So there's going to be some limited data based on that, but the evidence is pretty good in different topics. So I'll try to go through, and there might be better studies that I just didn't find, but I try to find some of the best ones and some of the most compelling ones on both sides. So let's go to the first one. So cardiac surgery probably has the best evidence. This one was in 2012, it was a University Hospital Frankfurt, and basically a prospective single center RCT, 100 patients, and they basically randomized you to a conventional arm and a Rotem arm. So the conventional arm had product resuscitation based on INR, PTT, fibrinogen levels, and your Rotem arm basically was based off XTEM, INTEM, HepTem, et cetera. They did have all the post-op patients, and so it started after you got out of the OR, and they included cabbages, valves, single, double, triple, all kinds, and aortic surgery, and every patient got full dose protamine reversal before they left the OR. So HepTem wasn't really in play, or was it, which I'll talk about later. But that wasn't really included in their data. And so their results were actually pretty compelling. So they had obviously decreased products because it was a more accurate representation of clotting, decreased cost, decreased ICU time, and they also had decreased mortality and decreased bleeding from your chest tube. So that was one of the better studies. Here's their graph showing, the last graph, sorry, I should have shown this too, but this is their mortality curve. That you can see the Kaplan-Meier demonstrate that the conventional arm, which is the red, had significantly less survival probability than the Rotem arm in the blue. And that was statistically significant. They also had chest tube output. And so the blue is the POC, which is a Rotem group, and the red is a conventional group. So they had significantly less bleeding at 6, 12, and 24 hours in the Rotem group. And then the other thing to think about with these, so Rotem, your PRBC is not part of your Rotem. So there's probably two things at play. Is one, you're doing a better guided product resuscitation for bleeding. So you're not bleeding as much, whereas you're giving the right factors in the right amount. But then there's also a dilutional component. So if you're getting a lot more FFP because you're using an INR, you're going to have diluted hemoglobin, and then you're going to get that transfusion threshold of 8 or 28 or whatever, because the transfusion threshold was the same in both groups. Does that make sense? So you got less product, so you had a less dilutional effect. So there's two things at play, and the authors even commented on that. So just to be aware of it, I think it's more related to just having the right product and the right amount gives you better hemostasis. So there was another study, Bollinger and Tanaka. They did a meta-analysis of 12 trials. 7 of them are RCTs. It was all post-op cabbages, but then they also had some valves in some of the trials. It was in transfusion medicine. And their results, they basically did the same thing, conventional or Rotem/TAG. Their results were less PRVCs, less FFP, less PACITs, and they had a signal to reduce mortality among all those 12 trials, but it wasn't statistically significant. They also commented about the dilutional thing because the targets were the same, the hemoglobin of 8 or 28, or depending on whoever your surgeon is. But I think it's definitely a combination of the two. So cardiac surgery, the Society of CV Anesthesiologists reviewed 292 different guidelines in a paper in 2019. And the result was they had this nice algorithm that is one of the cleaner ones that didn't show up very well. But I'll send this out. So it basically says, like, if you're using Rotem, it's this column. If you're using TAG, it's this column. And here's your values on this side, and you give this in the middle. So it's very easy, very clean. It makes it really easy to use. And this was based on reviewing 292 other algorithms. So it's a pretty good thing to have. So the next one, let's talk about OB a little bit, topic near and dear to my heart. just because of my wife, not because I like OB, but I don't mind OB, but you know. So the International Society of Thrombosis and Hemostasis did a systemic review of 93 studies of OB literature, and they did the study in 2020. And only 2 of those 93 were RCTs. I think it's a lot of multifactorial stuff, and the 2 RCTs they used weren't even that good that I'll talk about in the next one. And they basically were able to do a couple things. One, they created reference values, which is really helpful in pregnancies. So we know your coagulation is going to be different in pregnancy. We just didn't know how different. So they have reference values of your Rotem or your TAG based on reference values, and they agreed that it was the best for guiding transfusion and identifying risk, but then there was like more studies are needed. I definitely agree because there's only 2 RCTs for OB, and they don't really have a lot of relevance. That I have them on the next 2 slides. Cooper here, the OB department isn't really on board with it yet. Where I trained, they were like just kind of starting to use it a little bit. I think it's a lot of provider variability, but I think Rotem's the most helpful in general when your coagulation is complicated, not when you're on warfarin and you need to just see if you're therapeutic, or if you're on heparin, you need to be therapeutic. But things like cirrhosis, OB, malignancy, where your coagulation is different than a normal person, I think that's when it really helps the most. So it's kind of a shame that there's not more data on this. So the RCTs that we're talking about, this one was one of them. It's a FibTem guided postpartum hemorrhage, basically. So it was a double-blind RCT. They had 55 patients. And this one, it wasn't as relevant because all they did was, if your FibTem was less than 15, you either got cryo or you got placebo. And all they really showed was that you can have a threshold of a FibTem of 12 and not 15, and it's safe because they didn't have any difference in outcomes. So that's not as relevant to like, is this helpful or not? It's more of what threshold should we start giving these patients products? So if you look on the other RCT is the next one. This one was the women trial, which was a very big trial that you might have heard of if you did any OB or if you're emergency trained. It was a subset of the women trial that was a single center RCT, and it basically just checked the effects of TXA on fibrinolysis using Rotem. So again, not the question that we're trying to ask, but it's the only other really RCT there was. And then it was 167, and it was basically women with postpartum hemorrhage, and you got randomized to either getting TXA or getting placebo, and they just wanted to see what it did with your Rotem values. Not the question we want, but I just wanted to kind of summarize a lot of literature. It did show that your D-dimer levels went down when you got TXA, which we kind of knew. So liver transplant is one of the areas where the data is pretty strong. For a very long time, liver transplant surgeons would use Rotems exclusively when taking patients to the OR for pre-op. And even if your INR is 9, 10, doesn't matter. They do it based on your Rotem values to see if you need any products before, which I thought was interesting on 2 things. One is because we always have these like INR is this. We shouldn't really do a para, or we shouldn't do an LP, or we shouldn't do a central line, or all that. But surgeons have for a long time been comfortable taking somebody's liver out and giving them a new one when the INR is 8, 9, 10, just because they understand that the Rotem is much more accurately reflecting their coagulopathy. So this one was an RCT of 28 patients. There's a conventional arm where your transfusion criteria were platelets under 50, fibrinogen less than 100, or INR greater than 1.5, and then your TEG values, which were similarly correlating, or you'd have the TEG values where you would get products based on those. And then the results were your TEG arm used much less products, not kind of goes imply that you'd expect it to do that. But it also there was a trend to less bleeding in TEG, which speaks to the fact that you should be giving the right products in the right amount because it's a delicate balance with coagulation. So if you're giving too much of one thing, it's not necessarily going to mean it's a safer approach.
Can I just ask a question about that?
Yeah.
Was that guiding transfusion therapy during the surgery or pre-op?
Intra-op, pre, post, and intra-op.
Okay,
So like,
even if they weren't waiting
obviously,
pre-op.
to be able to do the study, the surgeons were already on board with using Rotems. Otherwise, they never would have gotten IRB approval, but it was basically the whole hospitalization, up to, I think, 30 days, I want to say. But it was, yeah. So the reason why they were able to do that is because surgeons have long used Rotem over INR. The next study for cirrhosis is that there's a couple good studies on cirrhosis. So this is 2016 in the Journal of Hepatology. It was before invasive procedures, same thing, conventional arm, Rotem arm, or TEG. And the results were there's less bleeding in the complications. And then 93% of the TEG patients, which I thought was really interesting, received absolutely no products because that kind of speaks to the fact that INR of blank doesn't mean you're actually having a coagulopathy. You could have a completely normal coagulation profile in cirrhosis because remember, all your clotting factors are down, your pro and anticoagulant. Another cirrhosis trial, Roux et al. In 2019. This one is variceal bleeding. And this was in the Journal of Gastroenterology. Your inclusion, or not inclusion, your same thing. It was a conventional and a TEG arm. Results were TEG had less products, less rebleeding, also a mortality trend. So this is your Kaplan-Meier with that, where you see the mortality trend is much better in the TEG arm. So you're starting to see the pattern kind of. I don't want to take too long on this because we have 15 minutes left, for example. This was basically a similar trial, but non-variceal bleeding in patients with cirrhosis. So the baseline characteristics were well matched, and your conventional arm was the same thing. You had these threshold criteria, and then in the TEG arm, you had this criteria, and the results were no change in transfusion requirements, and then TEG used less products. So using less products wasn't worse in this trial. You didn't require more blood. And it did have statistically significant less recurrence and less ICU days. And then these were the amount of platelets used, FFP, platelet, and cryo, which I thought was interesting. So just briefly on XTEM versus INR that I kind of already commented on. So we have, clotting is, I told you to dumb it down, but you understand that clotting is much more complicated than just a silly drawing. There's amplification stages throughout. So what really happens when you have platelet activation, which is done a lot by thrombin, is your thrombin amplifies your 11 to 11A, which is here. It amplifies your 5A, which is this one, and von Willebrand, which is this one, and your von Willebrand complexes into this step too. So it's not just a linear thing. So taking the platelets out when we run something like an INR is a big reason why it's not actually reflective of what your products are doing, because this amplifies itself in a cyclical way, and then it kind of builds to showing what your coagulopathy actually is. Does that make sense to people? So it's not, whereas your INR, you're just kind of saying you have this much factor 7 in your blood because we removed all the platelet component. So it's not going to have that amplification phase. So especially in cirrhosis, when people are complex, you can't just use an INR. And I think that's one of the most beneficial times to use something like Rotem that's a little more advanced. It's a similar product where if they're amplified platelets or activated platelets compared to just the platelet number, it makes a big difference because we see patients with HIT where your platelet count is 20, but they're having clots all over their body. I mean, it's a similar process. You can't just take a number to identify somebody's coagulopathy. I try to get a materials estimate. It's very hard to find. So this is the raw material cost of running a Rotem, which is the reagent cost for the 67 versus $2.22. I wasn't able to get the reimbursement for Rotem. I wasn't able to get any kind of financial stuff. If anybody knows, I think it's very interesting because cost has always been a big argument against it because it is a higher cost. You have to QI the people and the machines and buy these reagents, and it's an expensive investment to begin with, which I think has limited it in its use with other fields. But yeah, if anybody knows, let me know. So trauma does have a lot of data on it. We use it quite a bit in trauma where I train. What happened there? Do you see that online, or can you see my screen? Okay, there we go. Sorry. So this was a systemic review of 55 studies in 2014, published in Critical Care Medicine. And basically they looked at Rotem versus standard, and they wanted to find your diagnosis of coagulopathy, your need for blood, and a mortality difference. And it was not superior was the results. They didn't have any statistical data either way, but I think these were too mixed in terms of the patient population. And there was a lot of suggestive evidence, but none of them ended up being statistically significant. But the East guidelines, which if you do trauma, when you do your rotations, the East and the West have guidelines, and they're kind of considered a really good body to go for your data. They did a meta-analysis of 38 studies in 2020 to evaluate the role in trauma, and they did find a statistical significant decrease in blood products, procedures, and mortality when you're doing Rotem-guided resuscitation versus not Rotem-guided resuscitation. Okay, so that's a lot of the data. Let's get into some examples. I want people to try to interact and say what's clear and what's not clear. Yeah.
Sorry, quick question. Antiplatelets applied to neurosurgical procedures. Is there any data on that for using Rotem?
No data, but I have an example of that, and I'll talk about it. No data that I'm aware of. And that's something that I think would be almost impossible in the United States RRB system to find. The randomizing you to get DDAVP or platelets or not get DDAVP or platelets if somebody's saying that you might benefit from it with a head bleed. But there's nothing, and I don't think there ever will be in the U.S. at least for that.
No, we've had trials, not using Rotem, but you've had trials to look at whether or not you administer platelets. And
I just wonder, like, in a context of Rotem, though, if you're using Rotem to say whether or not you get DDAVP or not.
Yeah,
Because, like, I don't know if there's even data on Rotem in intracranial hemorrhage. I didn't find, like, any. So you would have to do that. I don't know. But hopefully there would be, because I think that's one of the has a big utility.
I was going to say, before you get to your examples, I think that in this, I don't know that we're going to get blood donation back to where it was pre-pandemic. Mm-hmm. And so I think that all of the studies, the consistent signal has been reduction in use of products. Mm-hmm. So I have a feeling that product price is going to go up.
Yeah.
And so I think that, quote, standard of care is going to be increasingly potentially unavailable. If we look at even institutions that aren't only like 2 hours south of us, they might just have like a couple units on hand.
Yeah.
They're not a trauma center, but even here, our blood bank has cut us off in some patients and said, look, you're not rationally using this stuff.
Especially with platelets, we've had nights where the blood banks tell us we have 1 unit of platelets in the whole hospital. And that's, level of trauma center.
So to that point, before you get to keep going, you think that it'll become more commonplace to utilize things like Rotem?
Anything that helps get product sparing stuff going on, or at least shows that it's safe to be product sparing, is probably going to be where it's at.
And I think to that point, you might not see a lot of large randomized control trials. People with a lot of technology, there's enough out there, you'll see it quickly adopted for that use. And, for us as a training program, we've started to see things like, thromboelastography examples bleeding into, large question banks, board review. I just think it's something that, wasn't, that you didn't hold the intensivists accountable for 5 or 6 years ago.
Right.
And even for people who I know who went to other institutions and trained who used it regularly, oftentimes, resuscitation was guided by like a pathology fellow or a pathologist, looking at the Rotem. This is something, to Lars's point, I think just like a lot of the things that we do now will be quickly adopted by intensivists and probably instituted, without any new mind-blowing randomized control trial.
Yeah, I think in terms of it, just physiology, it makes more sense. It's a better test that actually shows you what's happening. And you get to the point where it's like you don't really need that big RCT to tell you that it's better for the patient sitting right in front of you to do this kind of guided therapy. Okay, so again, with the patterns, we're not going to do that. So let's go through some examples. So here's the first one. No, don't look. Nobody look. It froze. Sorry. All right, so somebody that wasn't looking can do the first one. Sorry, it's like really delayed on my iPad versus the screen. Okay, so here's an example. This is your printout, very common. So instead of having to squint and look at the values, I'm just going to tell you. So the MCF was low, which is here on your intim and extem, so low. Your MCF is normal here, so this is okay on the FibTem. And then your APTEM was equal to your, this one, to your XTEM. So that's easy enough. So what does that tell you? If your APTEM and your XTEM are the same.
You get platelets?
What was that?
You get platelets?
Yeah, so that's the right answer for this one. The APTEM and XTEM are the same, so it's not fibrinolysis. So you have a thickness problem, right, like Brian was saying. So it's not the fibrinogen, though, because your fibrinogen height's normal. So if it's not thick enough, then you're left with platelets. So there are qualitative platelet assays that you can run on Rotem. Cooper doesn't have them, but they exist. I kind of ran out of time and stuff I want to talk about. So you can see which receptor is blocked, which is not blocked, et cetera. But this will tell you that it's either a number or a qualitative issue. And then you have your lab value for platelets. So say your platelets are 300. So it's not a quantitative issue. So that'll tell you that either they took an antiplatelet, they got an antiplatelet, et cetera. So you can think of the utilization for that. So like what Brian was saying in terms of somebody comes in, they have a big head bleed, you don't have their history, but like aspirin's kind of there or not in their chart. Maybe they were taking it. If you run something like that and their platelet aggregation is actually impaired, and that you'll have that result in 10 minutes essentially. So this is something that's a very fast, actionable thing in something like a head bleed. Or say somebody comes in and they have acute coronary syndrome and you're wondering, are they actually taking their dual antiplatelet at home or not that they were on 6 months ago? And they have a completely normal Rotem, they probably weren't taking it. So maybe you should reload that patient. So that's another way that you can use this. Obviously that's not data proven. Or the Plavix washout. So say somebody has Plavix as a home med, and they need to wait the 5 days, but then you run these and they really don't have any antiplatelet effect for whatever reason, then maybe you can move up that surgery a couple days, and it's better for the patient to not be sitting in the hospital for an extra 5 days. So that's another one. So we'll do, does that make sense with the thickness thing? So you have this FibTem part in the middle, that's all your fibrinogen mesh, and then you have the platelet part around the, so if something is not big enough this way, you need to look at the FibTem to tell which problem it is. Does that make sense, everybody? Okay. So next example, just I'll give you the values again. So your clot formation time is high on the XTEM, and that's this one. And your clotting time is high on this one. And then INTEM, your clot formation is high. And your FibTem, this is high, and then this clot is really narrow. So your MCF is low. It's only 3. I remember on the other slides, 10 was about normal. And then you look at your APTEM, and APTEM matches your XTEM, so lysis is not happening. So that's one answer that's gone. What do you think? So the problem with this one is fibrinogen. So the fibrinogen is low. I'm asking more generic instead of like a clinical scenario, but so your fibrinogen is low. So the treatment with this one, you give cryo, and notice again compared to running a lab fibrinogen, that takes 30 minutes to an hour to 2 hours sometimes. You had that result in essentially 185 seconds that it took to run, because then you can see the thickness. So that's 3 minutes, and then you're already given the right product instead of waiting for the lab. All right, more examples.
And to your point about speed, you're more than welcome to sort of sit. Sometimes you have a clinical pretest probability. You can sit in the room and watch it read out. You don't have to wait for the printout. You can catch it right.
It's so fast.
When it's very clear, you can catch it right in the middle and then go to work. You know what I mean?
Yeah, like the trauma centers have it up, and it graph is live time. It's not like you need 60 minutes. So like when Phil would run them for hearts, or when we'd run them for hearts, I'll just go and stand there, because you get your actionable data, your clotting time, your clot formation time in like 2 minutes. So you just can stand there, say, oh, those are normal, and then circle back to it. All right, so what about this one?
Can I ask a question about the last one?
Yeah.
Would you also give FFP to that patient, or is the fibrinogen just enough?
So I would start with fibrinogen, and it's a good question because your clotting time is long on this one and this one. And that is probably the result of your fibrinogen going to fibrin, sorry, my handwriting part. So I would give cryo first and then see if it corrects or not. So usually if you have the fibrinogen, if that's really reduced, I would do that first. Because it might be, that could be an FFP problem, a clotting factor higher up, or it could just be your low fibrinogen. Does that make sense?
Yes, thank you.
Okay, so next example, so your clot formation time is high in your XTEM. So that's this one. Your lysis is 100% on NTEM and XTEM. And then your APTEM does not equal your XTEM. So what's going on with this one?
Hyperfibrinolysis.
Yeah, so exactly. So anytime you see your APTEM or your HepTEM be normal and it doesn't match what they're supposed to match reflectively, you're done. That's the easiest one to interpret. So you give TXA, don't overthink it, that's the end of it, and then you can reassess to see if that helps. Next one, so post-op heart, for example, you have no results on the MTEM, so it just keeps going. And the HepTEM is completely normal. So which one is that?
Someone forgot the protamine.
Yeah, so it's heparin toxicity. So you have too much heparin on board. You get protamine. Common, not just post-op hearts, but say somebody flushes a dialysis catheter inadvertently and it's dwelling with 5,000 units. It happens every now and then they're bleeding and you run this and you would never have thought to give protamine, but then you're like, oh, I remember now they had a Shiley that we had to use because they were coding or whatever reason.
Yeah, the hep block is a great example.
Yeah.
That's a great example.
We had that on our EM boards like every year. It was on our in training every single year, that question. And then post-op hearts, the pearl of that is you always include the HepTEM on your post-op hearts. They could be lysing because they're just on circuit and all that, but you really want, because you can only pick 4. So you really want to, and you can always rerun it, which isn't cost effective, but you got to, at least until the first one, and you know it's not the heparin that they got in the OR, you have to include it because that's an easy thing to miss and it's an easy fix. So I want to do a little bit next level on that topic specifically because it's really pertinent to here. So this was out of the Korean Journal of Anesthesia. They did a couple things on different dosing. So if you notice for heparin toxicity, it doesn't have to be like the last example where it doesn't even get a clot. You see? This one, it gives a clot, it's just super weak, super prolonged, but then your HepTEM's normal again here. So it's a lower dose of toxicity, but you're still toxic. So it doesn't always look like this one and this one. And then the last one that I think is important to talk about is protamine overdose, and this is new in terms of preparing for this talk, for me at least. So anytime your HepTEM is, and please ask questions, I'll try to draw it out on the next one because it's hard. If your HepTEM's clotting time, like on this example, it didn't blow up very well, but this clotting time is much higher than the NTEM. So what does that tell you? So that tells you that you're taking heparin out of the picture, right, by the heparinase enzyme, but the clotting time's worse. So how does that make sense? So when somebody leaves the OR from cardiac surgery, they get a dose of protamine. And protamine in isolation, it works because it binds heparin and then both molecules are neutral. But free protamine is actually an anticoagulant and it blocks platelet formation, factor 5 and factor 2. So if you have too much protamine, that'll make you toxic. So this was actually a pretty good study in UT Southwestern in 2019, and they tried to explain this phenomenon of protamine overdose. So they looked at your HepTEM clotting time and your NTEM clotting time in post-op hearts respectively, and they actually gave product based on that. So they had people where they had too much protamine, meaning that their HepTEM clotting time was bigger than their NTEM, which I'll try to explain again on the next page. And those people actually got FFP, so they were trying to neutralize protamine and overcome it by giving more factor 5 and more 2A. And then the clotting time's normal. So if somebody comes out in their post-op heart and you run your Rotems and it's looking kind of normal, but your HepTEM is much larger than your NTEM, think of this, and I don't think we ever do, because this is a big center that uses standard CT protocol, and 75% of their post-op hearts had too much protamine. So the dose they were giving was too high. So to draw it out, so you have, sorry, and bear with me, so you have heparin, protamine molecules kind of floating around, and they work because they bind each other. So if you have too much protamine and you have a bunch of P's here, and you use heptem to block heparinase, so you block that, that means these are even more exaggerated because these two heparins used to be able to bind with these P's. So you have even more free protamine molecules available on the heptem. That's why the heptem can be even more coagulopathic. Does that make sense? And the worst drawing you've probably ever seen? Okay. Because I had to like really go over that because this is a new concept for me, but I think it's very relevant for our practice here. Okay, so another example. This is from
Daniel.
Yeah.
Daniel, going back to the heparin toxicity in post-cardiac surgery patients, like, what is the incidence like? Is that very rare where they still have too much heparin on board after protamine reversal, or was that?
I think it's rare because, especially reading on the protamine stuff, it looks like most protocols give a big dose of protamine and it's too much. So I think it's rare, but, and I didn't know that until preparing for this because most of the places give X amount of protamine. It's just like the standard big dose. But they're a pretty big center, UT Southwestern, and 75% of their patients had too much protamine, not the other way around.
It's also important, that sometimes when they give protamine in the OR and they develop an urticarial reaction or have a sudden temporal drop in blood pressure, they'll stop it. So then they may have not gotten their complete dose, and you may or may not be privy to that information when they come out.
Right.
So I think, rather than just like incorrectly dosing for the heparin weight that you got in the OR because everything's so standardized, sometimes there's things that creep up where they may not have gotten an appropriate dose because of a reaction.
Yeah, I thought the protamine stuff was really interesting. So this example, it's from an article in Thrombosis that had healthy controls versus blank disease process. So, and they're talking about this disease process. So your A10 is high and your MCF is high in all lines. So what is that? What's the basic thing for that? Well, what's a generic term? So you're too thick, too big of clots.
Hypercoagulable?
Yeah, so you're hypercoagulable. So this was actually on COVID patients. I went too fast. Hold on, sorry, online. It's hopefully going back. Sorry, it's frozen. There we go. Okay, so this is COVID patients. It's from last year. I thought it was really interesting. So it shows you really how coagulopathic they actually work, because look at how big the clot is compared to healthy control. So it's a really thick, big, strong clot. And you see how the angle is a little steep? So this is classic hypercoagulable state. And this actually correlated to high IL-6 and high CRP values. So they only included ARDS patients. So I thought retrospectively, obviously, it would be interesting to see if maybe this subset of patients with these kind of markers would have benefited from heparin therapeutic dose. I know that there was trials about how it's actually harmful, so we stopped doing it, but I wonder if there was a subset that would have benefited from, and if we could have identified them using Rotem. So this malignancy, things like that, you can run it and it'll be a similar pattern. Here's another example. So we're kind of out of time. I was going to see if people could guess like what therapy people were getting. What just happened? Oh, it's hearing Siri for me. You guys still with us? Sorry.
We don't see the.
Yeah, just bear with me.
No, you're good.
Siri was basically just like, you're not going to share your screen anymore.
Do pregnant women show up like that hypercoagulable COVID patient, or not to that degree? Do you know?
Not to that degree, but their values are similar. So that's why the one that registry I talked about was helpful, because they have a hypercoagulable pattern, and they kind of teased out reference ranges. So this, I just wanted to kind of show like what different treatments were given. This was a transfusion algorithm in the Korean journal I spoke about. So from this step to this step, nothing was given because it's post-op. And then from here to here, based on this, so you see your FibTem is undetectably low. So you got your 4 grams of fibrinogen. And then from 3 to 4, you got more fibrinogen because the clot was still a little thin and your clotting time was higher, and you end up getting PRVCs. So that was just kind of something I wanted you to keep in mind, because there are places that will serially run it to guide your resuscitation. So you shouldn't just do a one and done type strategy. One more example. I have a couple more examples, but this is pretty much out of time. So this one, your FibTem and XTem are normal, your NTem is high, and your HepTem is also high. So what does that mean?
There's an intrinsic factor deficiency.
Perfect. Yeah, don't overthink it. It's intrinsic problem because your heparin's not normal, so it's not heparin toxicity. So this one was a case report of a hemophilia A. So you'll have an intrinsic defect and rapidly identified instead of a send out lab that takes 10 days. I mean, you won't know exactly what factor. There's different ways to identify it. But, one more. So vitamin K antagonists. This one was a pre-op warfarin cardiac surgery patient. Got a dosing of FFP, the 10 ml per kg, which is a little on the low side. But their XTEM essentially went from 153 to 116, so didn't completely correct. And then they reassessed it to see if they could take the patient to surgery, which obviously was the right move because it hadn't corrected yet. And then they gave 4-factor PCC, and then it corrected. So that's just kind of how you can use it to trend your values instead of just blanket saying 10 to 20 ml per kg FFP will reverse all INRs. Because that's not necessarily true. They could have gotten in trouble with this patient because they weren't reversed. And then last one I'll talk about is DIC. The pattern is a little different. So you have stage 1 where you have this kind of hypocoagulable state where it's considered somewhat relative. Your protein CNS values are lower and they're consumed faster, so you're more readily clotting in the first stage. And then you have a lot of fibrinolysis, so you see this breakdown. And then you get to stage 2 where just all your factors have been depleted, and that's when you're hypocoagulable. So you get this kind of pattern, which is your flute, I think, wine glass pattern. That's when kind of all your clotting values are down. So this is a clinical example, and it's the last one, where it can be used because this is a patient that's 58, was bit with a hump-nosed pit viper, and they had all their labs were consistent with DIC. But then they ran Rotem and everything's normal. And fibrinogen is even on the high normal side. So not really consistent with hypocoagulable DIC. It's more hypercoagulable DIC, so the treatment's different. And clinically, she actually had purple fulminans and was hypercoagulable and having microthrombosis. So, and the Rotems would have identified that in 5 minutes, give or take. And it completely changes the management.
Did they heparinize?
Yeah, they did. Yeah. So they heparinized. It didn't work because she progressed to. Some of it worked, but
Yeah.
she still had a pretty significant outcome. This is just a case report from a couple years back. Okay, I think that's the last example. Any questions? I know it's the last stuff. And those are the latest girl pictures.
We'll get this up on the drive and up online because I'm sure everyone in the room probably needs to digest it a couple of times. But I think these are absolutely, going through the data, I just gave you a lot of credit. Going through the data and giving those examples. I remember when we went live with Rotem, obviously Dr. Nolan, Dr. Coach took it on the chin to try to be super users for Rotem. But even when I tried to sit through the device manufacturers and specialists, it was really hard for them to convey this in a way that was easy to learn and to apply clinically. So, I give you a lot of credit for that. I will say, trying to troubleshoot medical bleeding, I think a lot about the post-cardiotomy patient because time is so important. When you think about trying to advocate for resternotomy and, and the delay and, where the mortality goes. But then to go back for medical bleeding, where the mortality goes. And some of the examples, especially when it comes to, supplementation of fibrinogen, I think is really important because we can all appreciate, giving pooled cryo, expecting it to work, and then waiting for more fibrinogen levels and having more bleeding.
And it takes
where you can you know, in a matter of minutes, you can treat and then reassess and then retreat way before you would ever get, you know, some of the basic, you know, coagulation panels. I think fibrinogen's turnaround time is low.
Yeah, it's especially with how long it takes to get cryo. So you have to wait hour and a half to get the lab value, then you order your cryo, then maybe it's hanging in an hour and a half, 2 hours.
Yeah.
Especially in obstetric hemorrhage, particularly low on fibrinogen values. I didn't have time to go into the pathophys behind that, but a lot of the papers said the same thing, that they're universally will have lower fibrinogen. So I just think it really changes management in a lot of different situations. You just have to kind of commit to learning how to use it.